Good afternoon and welcome. We will get started in just 2 minutes. Good afternoon. Welcome. We will get started in just 1 minute. Good afternoon and welcome to CMQCC's webinar on partnering with doulas to improve perinatal outcomes and promote birth equity. Our facilitator today will be Holly Smith, and I will turn it over to her in just a minute. We're going to go through a couple of housekeeping slides first. Everyone should be muted, and we would love to receive your questions. We will not be taking live questions today, but instead, please submit your questions in the Q&A box on your toolbar. And as we respond to those questions, you will see the question and responses there in that Q&A area as well. The webinar is being recorded. We've already begun the recording, and we will post that on our website on our webinars page, as well as this slide deck within 7 days, no more than 7 days from now. And that's also available on our YouTube channel. The slides are a free download, and we ask that if you end up using these slides and sharing with others, please use them in the format we've designed. If you add content, please use your own branding and logos. And I just touched on this. If you modify any of the slides, again, please substitute your logo, and please refrain from using the CMQCC logo. Today, we are here as an educational resource, and you should check your local facilities' level of care and patient populations, and don't rely, please, solely on what you hear here today. But we're happy to be here and share these resources and hear from our expert panel. If you would like to receive continuing education hours or contact hours, we will be sending out an evaluation 24 hours after this webinar. Please complete the evaluation. Either way, please complete it. And at the end, you'll receive an extra question around receiving your contact information so that we can follow up, send you that certificate. And we will send that within 3 business days. And again, if you are looking for those continuing education hours, please stay on the call at least 50 minutes, 50 minutes. And here I'm just going to pause for a moment for you to take a look at our inclusive language notice. That will set the stage for some of the language we use here on this webinar and in other CMQCC webinars and communications. And again, this will be available in the slide deck if you'd like to read it, so we can get started. So I'm going to turn this over to Holly Smith, who will introduce herself and the expert panelists we have with us today. Thank you.
Hi, everybody, and thank you for joining us today. My name is Holly Smith. I'm a midwife, and I'm also the project lead for the CMQCC Toolkit to support vaginal birth. With me today are 2 panelists who will be having a discussion and answering some questions at the end of a short presentation. The first is Michelle Sanders. She is a certified doula and also the founder and executive director of Beauty for Ashes Maternal Wellness, as well as Ann Fulcher, who is the manager of the volunteer doula program at UC San Diego Health and also a certified doula. Today's objectives, I won't read through here, but I hope that what you get from today is an understanding of how and why doulas are so important to improving outcomes for birthing people, and even perhaps summarizing a few of the strategies for partnering with doulas at your facility. Just a reminder, this webinar is number 4 already in a 5-part series. You can see the other 3 webinars that we've already recorded at the CMQCC website. It's right there on the bottom left, the link, and then additionally there's a QR code you can scan, which will take you to the part of the website that has all of the recorded webinars. Coming up in October, we have the final one, which is Community Birth, Improving Transfer of Care. All right, so let's get started. If you have been in this webinar series in the past, then you have heard this part, and feel free to get up, get your cup of coffee or whatever snack you want to eat. But for those of you who haven't seen this, I encourage you to stay. So there is definitely an elephant in the Zoom. In fact, there are many elephants in the Zoom, but today I'm going to talk about 2 of them. First of all, maternity care is failing lots of pregnant people, those on the margins, Black and brown people, rural folks who are geographically isolated, the list goes on. And I know that everyone in this virtual room is doing the best they can, but sometimes it can feel like we are pushing a boulder uphill in an almost Sisyphean effort to reduce mortality and morbidity, while all around us, there is this entire ecosystem. So there's a lot. We're up against a lot, as you can see by this slide. There are many systems level influences that confer risk during pregnancy. And so the improvement ecosystem does not just center around the clinical improvements we can make. And I think if we're being honest with ourselves, there might have been a time when you thought that. And in fact, I know I did, where if we just do better, implement more checklists, change certain behaviors, we will eventually get to the point where everyone's outcomes will be the same. But that's just not true. And so I just want to put it out there that there's a lot more to changing outcomes than simply the clinical improvements. Now let's talk about the next elephant in the room. And that's that we're talking about partnering with doulas. And in the other webinars, we talked about midwives and community birth. And that even that word, doula, can be triggering for some people because it's not part of the dominant care model. And some of us still have our feelings about what a doula means and what a doula should do, and particularly what a doula should be doing in the hospital setting when there's another care team there already caring for the patient. So I get that, and I nonetheless hope that you will listen to this webinar and view this webinar with an open mind, and just realize that the whole reason for this is because we're attempting to provide the most patient-centered care possible. Patient-centered care means providing care that is respectful of and responsive to the individual patient preferences, needs, and values, and ensuring that those values are what guide all clinical decisions. We also have to address, however, that there's no singular intervention that is a silver bullet. And so it's time to use all the tools to improve outcomes. And that goes for partnering with doulas. Partnering with doulas alone is not going to change everything, but it's a really important part of our next steps. And we also just want to note that we believe doulas are critical patient advocates and connectors to services just as much as they are there for the patient for labor support. And finally, we can't talk about doulas unless we also talk about community birth. And one of the things we want to set the stage with is that we believe community birth is safe. That means home birth and birth center birth, when there are trained and skilled providers, when there's ongoing risk assessment, and when medical consultation and higher levels of care are easily accessible. All right. So this might look familiar to some of you. We're going to back up and look at where we were a few years ago with cesarean rates in California. Around 2014 and 2015, you all probably remember, is when everyone across the nation was talking about cesarean rates. Around that time as well, the Maternal Data Center at CMQCC came into being, and we were able to see in real time that, in fact, cesarean rates, particularly NTSV cesarean rates, being cesarean rates for the lowest risk people, were much higher than they should be, meaning many people were having unnecessary cesarean sections. So we started the collaborative and introduced the toolkit to support vaginal birth. And you can see that during that collaborative period there with the orange square, that cesarean rates reduced. They decreased considerably in California, actually, and a little uptick there during COVID, but overall a pretty significant reduction. Here's just a quick graphic of what the participating hospitals utilized in order to decrease cesarean rates across the state. It was a combination of a few things, and hospitals didn't use just one thing. In fact, it was always a combination of 2 or 3. The most common, however, was staff education about normal labor. We also shared unblinded provider cesarean rates with each other or amongst medical groups. We also implemented lots of checklists and huddles and patient education during labor, et cetera. Those were the most common. But you can see down there in the red were the least common things, introducing doulas being one of those, and then way down at the bottom, introduction of midwives. So we did a lot. You all out there that participated in the cesarean reduction program across the state did quite a bit, and it worked. However, once we were able to look at cesarean rates differentiated by race and ethnicity, it became clear that there was much more work to do. And this is the same across the nation. You can see here that during that same time frame of the cesarean collaborative, that C-section rates decreased for every race and ethnicity, but that disparity, that gap between Black and white remained. So birth equity, that's why we're here. I imagine that the folks over at the National Birth Equity Collaborative, when they came up with this definition, that they took a lot of time and were intentional about the words that they used. And you'll see that birth equity here does not mean when all outcomes are equal for everyone. And I mean, that's the goal eventually, right? We don't want that disparity gap anymore. Certainly that's the goal. But in this moment, birth equity means the assurance of conditions of optimal births for all people. But how can we assure the conditions of optimal births for all people if we aren't willing to figure out what those disparate conditions are and the racial and social inequalities that go along with that? And we'd have to do that in a sustained effort, right? And the only reason I bring that up is because this work is hard. So if you think back about that slide that showed the elephant in the room, and I talked about the Sisyphean effort of pushing the boulder uphill, it feels that way because this is a bit different in terms of quality improvement work, right? If we are really wanting to achieve birth equity, it's a different mindset. It's constant gardening, meaning there's no one-offs, takes emotional intelligence, takes radical empathy. We have to be innovative thinkers. We have to do a very hard thing of deconstructing harmful power centers, which takes humility for the people in power right now. It means we're talking about entire systems change, and we have to think about all the upstream social determinants of health. So that's a lot there, right? And that really isn't consistent with the typical clinical quality improvement efforts that we've been able to utilize in the past. Because those things are fairly cookie cutter processes. It's where we set target goals that are simply good enough. We start with the low hanging fruit in order to achieve that good enough. Sometimes we start and stop. And it ends up that we try to change behavior, but we may not be changing the hearts and minds of the folks engaging in the behavior. Now, this is not to say that the typical way we do quality improvement, that there's anything wrong with that. I'm not disparaging that in by any means. But what it means is to achieve birth equity, we have to think and do things differently now. We don't have any other choice, really. So the work must absolutely be intentional. It's time now that we have to utilize strategies that consider the root causes of disparities. We have to think about community needs and wants in our approaches to quality improvement. And that's the whole concept of patient and community centeredness. We have to incorporate improvement measures that evaluate things like respect and dignity and implicit bias in childbirth. And we have to have the humility to accept that what we're doing right now is not working for everyone. So really in a nutshell, we have to use all the tools in the toolbox, right? Not just the low-hanging strategies anymore. And so that's the story of how we got here, and how the toolkit to support vaginal birth now includes clinical improvements that consider the root causes of disparities. And that's why partnering with doulas, as we're talking about today, is in the toolkit, as well as midwifery integration and team-based care, which you can view in the previous webinars. And of course, we're not the only folks that think this. This isn't coming out of nowhere. The Joint Commission, for example, put out this paper in the Sentinel Event Alert back in earlier this year, I believe it was February, about eliminating racial and ethnic disparities causing mortality and morbidity. And they note that we must provide support and options that meet the needs and expectations of patients, including those who want to deliver in the home or the birthing center environment. And additionally, down below, it means that we have to think of all the ways that we can promote labor progress and labor support. In fact, ACOG says, and this is a really strong statement, that the published data indicate that one of the most effective tools to improve labor and delivery outcomes is the continuous presence of support personnel, such as a doula. Given that there are no associated measurable harms, this resource is probably underutilized. I like that they say probably underutilized, but absolutely, if it's one of the most effective tools, and we're not really doing it yet, then it's underutilized. And of course, there is a deep bench of research and position papers and policy guides on integrating doulas into our current system of care, or partnering with doulas, I guess I should say, into the current system of care. And you can find, I believe, most or all of these references in the toolkit. If you're looking for it and can't find it, just let me know and I will send those to you. Now, the interesting thing is that doulas have been present throughout history, much like, I guess we could think about midwives as well. The concept of having a companion providing support for the birthing person dates back to prehistoric time, and that is evidenced here by these archaeological findings and carvings. However, the contemporary role of the doula first emerged from the grassroots natural birth movement in the United States in the 1960s. And it is thought that it was first used in the US in 1969. But some historians will argue that the word doula, or a similar word, exists even in the Bible. So it goes back a long way. What is a doula? A doula is a trained non-medical professional who supports and protects the patient's physical, emotional, and informational needs during labor. Doulas also have an important teaching and advocacy role during pregnancy and during labor and during the postpartum period, which I have really put in bold there, because I think what we're seeing right now is the significant effect of that really, I guess, ignored part of post-pregnancy, right? Up until very recently, we were kind of ignoring what happens in the fourth trimester as we're calling it, during the postpartum period, and also understanding that many deaths and many morbidities occur during that time frame. So some doulas provide support during and after miscarriage as well, and even abortion. And there are even end-of-life doulas who support people in hospice or at other times as they prepare for end of life. This is a wonderful guide from the National Partnership for Women and Families, which is one of the resources we use in the toolkit. You can use that QR code there to find this reference. But they point out really succinctly and really well the 4 key roles of the doula. First of all, they provide information about childbirth and foster communication between birthing women and people and members from the care team. They play a really important advocacy role, as we'll get into a little bit more. They also, of course, provide that practical support that we all think of when we think of doulas, meaning position changes, labor support for a non-medicated birth, hands-on support, massage, acupressure, etc. And of course, providing emotional support for both the confidence and sense of control during labor. The toolkit rephrases this a little bit and goes through the elements of doula care. So this is one of the tools you'll find in the toolkit. And it kind of really nicely shows what doulas do and what they don't do to make that really clear. So there's a teaching element to what doulas do, especially during that prenatal period, providing that physical comfort, care, and support. Patient advocacy. Patient advocacy means that doulas really act as that bridge between the patient and the provider. They provide often culturally congruent advocacy and informational assistance. They preserve and support respectful care and privacy and dignity. And they are the connection, if they are a community doula, a connection often to social resources. And again, speaking of the postpartum period, they provide that postpartum support and connections to care. What doulas do not do. So doulas do not provide clinical or nursing care. Okay, so that means all the stuff that goes along with that, physical assessments, catching the baby, fetal monitoring, medication administration, anything that has to do with the clinical or nursing care of the client, the doula does not do. They also don't diagnose or give medical advice. And they do not or should not be making decisions for the patient or pressuring the patient into certain decisions. And finally, they don't leave the patient during labor. Now, there are some exceptions to this. You will, of course, see a doula leave to go to the bathroom or grab a snack. Also, in the doula collective model, where doulas work together as a team, you might see doulas change in and out, particularly over the course of a very long labor. But in general, doulas are there the entire time during the labor and up to the birth and into that golden hour for lactation afterwards. The benefits of doula care are many, and this resource is directly from the toolkit. You can also find the research that supports this in the toolkit, but cesarean birth is less likely with a doula, operative vaginal birth, the need for oxytocin, epidural anesthesia, and the use of pain medication. What's more likely with a doula is a spontaneous vaginal birth, shorter labors, higher APGAR scores, breastfeeding initiation, patient-centered care, a positive birth experience as reported by the patient, and lower cost. And this quote here says, in comparison with women receiving no continuous labor support, women with doula support were an impressive 39% less likely to have a cesarean birth. The toolkit also attempts to break down the difference between a hospital-based doula and community doulas or doula collectives. And luckily, I don't have to go much into that today because our panelists will break that down for you. Hospital-based doulas, as the name says, are doulas that are based in the hospital setting, typically through a volunteer role at that facility. And community doulas or doula collectives work within a community, sometimes in a nonprofit organization, and they serve the women of and birthing people of that community. And it's really important, and I think we will also talk about this a bit more with our panelists, that understanding systemic racism and disparate birth outcomes is critical to understanding community doulas in modern times. I've put together a little graphic, which I think folks are probably gonna smile and laugh at a little bit because my graphic design, I'm not very good at it. You'll see that here. But in any case, this kind of really, it breaks down for us how systemic and structural racism have led to disparate birth outcomes and the touch points where a community-based doula may be able to attend to or assist with that. So if we start at the top with systemic and structural racism, leading to segregation and redlining decades ago, and toxic daily stress, which leads to physiologic changes and mental health exposures. Looking at the segregation and redlining, that led to a built environment with polluted areas, a built environment without healthy green spaces, neighborhoods without proper transportation, and inadequate access to healthy foods, also fewer health centers and hospitals, poorer school districts, etc. That led to toxic exposures, fewer places to safely exercise, food scarcity, and access to fewer providers and less access to health education and fewer social services, which then altogether form the perfect storm of disparate outcomes. Again, this is about as simple as you can get for understanding systemic and structural racism in our nation. But it's also important to see then how a community doula who is familiar with that person's community, familiar with that person themselves, as well as might be culturally congruent or racially congruent or language may be the same, have various touch points where they may be able to affect that person's outcome, whether that's helping them to deal with whatever stressors they're dealing with, they can recognize certain physiologic changes, particularly in the postpartum period, or mental health changes that might need to be attended to and can help them set up those appointments. They might have access to a better understanding of where the client can get transportation or connect them to services for healthy foods. So you can see there's just a ton of different places where a community doula can interrupt the harmful process that's occurring in the hope that they can help set up the patient for the things that they need. All right, I'm going to start this video. If you cannot hear it, Gina or someone from CMQCC, just let me know. Oops, I have a feeling you can't hear that. Is that right, or could you hear that?
No, we cannot.
Okay, that's what I figured. One sec, please.
My name is Lorna Leverett. I am a community doula for the AIM Doula program. The AIM Doula program is an LA County sponsored program that offers doula services for African American moms.
Being a first-time mother is, only thing I can say is there's no manual.
So go ahead and get some rest, Nikki.
Thank you. Thank you. I'll be back.
Okay. Doulas provide emotional support, educational support, and physical comfort. This program is all about teaching African American mothers about birth, telling them their rights, their choices in the hospital, and just making sure that they have better outcomes.
I am 36 weeks pregnant, so I am in my 9th month. This is my 2nd pregnancy, and having the doula, Lorna, has been a big help. There was things that I kind of just winged the first time and kind of went with whatever I was told or read or whatever. But this time I've actually been researching things that I've learned from our sessions with Lorna. It has empowered me, especially going to the doctor when they say things, I'm kind of like, okay, yeah, I already knew that.
The statistics show that in Los Angeles County, the Black infant and maternal mortality rate is disproportionately different than the other racial groups. Black infants are dying at a higher rate, and Black birthing persons are dying at a higher rate because of racism and the physiological toll it takes on Black birthing bodies. And so with the AIM Prevention Initiative, which is the African American Infant and Maternal Mortality Prevention Initiative, our goal is to reduce that rate by 30%, and it's a Los Angeles County priority. And we do so by providing doula services for free.
Babies have reflexes. So what you want to do is bring your nipple to the top of her nose and down so you can engage a gape.
Okay.
when African American women sign up, what they get is 3 prenatals, continuous labor support, and 3 postpartums. Prenatal is mostly education and infant feeding and infant care. Postpartum is mainly infant care done by me while mom rests. We're done. We're done. It's okay. It's all right.
If I reached out to Lorna, she was able to give me either some kind of advice or she was able to send me to someone who did have advice, because she's dealt with so many different babies and so many different pregnancies that she's able to give me advice, and I trust her advice.
How are you? I see how much of a difference it means to these women, especially first-time parents. All of the ligaments loosen up for baby to come down easily. And even though it's helping the baby, it hurts her. So when we help relieve that pressure, it feels good.
I love the information and the research-based information that's provided by Lorna. I think it brings us together more, just to love and support one another and be there for each other throughout the process.
Over 80% of our clients report that having their doula reduce their stress levels during pregnancy, labor, and delivery, as well as 95% have had an overall satisfaction with their doula and their doula services.
Things aren't just happening to my clients. They know their choices. Everybody deserves that up close and personal support, beginning, during, and the end.
When you have someone that is invested, but also still not in your family or not as close to you, they're kind of like a third party, but they're still invested in your health. That's something that you can't buy. So I was very, 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 very grateful. It was kind of the best thing that ever happened to me.
All right, everybody, I'm going to put my earbuds back. Hopefully be able to hear each other. All right, do a little sound check. Can you hear me now, Gina?
Yes, I can.
Great. All right, we're back. So in the toolkit, you will find strategies for partnering with doulas. And these strategies are separated into administrative strategies, clinical strategies, and educational strategies. For example, and there are many more than these in the toolkit, but I just wanted to note a few here. The toolkit notes that one strategy for partnering with doulas is that you ensure that doulas at your facility are empowered to remain independent champions for patients, and we will talk with our panelists a little bit more about that today. The policies at your hospital should reflect that doulas are not visitors in the typical sense, meaning bound by time limits or other visitor rules. You should have updated policies to include doulas as support people in the operating room as well. And hopefully you are intentionally cultivating a culture on the birthing unit that values physiologic birth and patient choice. One thing that we have realized in the midwifery community is that in facilities that don't intentionally cultivate that culture of informed consent, patient-centeredness, physiologic birth, that midwives tend to not be able to practice there very long because their philosophy of care is not supported or understood, right? And in the same way for doulas, if your unit is not attempting to understand that patient-centeredness and physiologic birth and all the things that go around with making the patient the center of care, then doulas aren't going to be welcomed there either. So it's something that goes hand in hand. The other thing is to connect to community-based doula programs and welcome community-based doulas at your facility. And you might even think about creating opportunities for interprofessional education that include doulas from your community or doula organizations with whom you have formed a relationship. Now, again, there's many more strategies in the toolkit. I'm not going to walk through them one by one. Some of them are very self-explanatory and don't need much more than simply stating what the strategy might be. And others, you'll realize that facilities are going to come at it at different ways, but hopefully achieve the same result. For example, this last one here, creating opportunities for interprofessional education. Different facilities might do that in different ways. But in a nutshell, doulas are a part of the team. They're an integral part of supportive care for the patient. And when they have the same goal, it means they're on the same team. And I know that can be really difficult at times for nurses, physicians, midwives in the typical hospital facility to understand because it's an outsider coming in. And Fulcher today will talk about the benefits of a hospital-based volunteer doula program, where doulas are actually really incorporated in and considered part of the team. But nonetheless, even those doulas have to be able to keep their independence so that they can advocate for the patient at all times. And of course, doulas are part of the team because the patient says so. And patients being at the center of care means that what they say, we have to give value to. There is a lot going on in California around doulas. For example, the Medi-Cal doula benefit. There are various pilot projects and even doula research. There is a growing community of community doula programs and organizations across the state. And there's now also a growing popularity in hospital programs as well. This is an amazing resource. If there's one resource I give you today, it's this one. This is from the National Health Law Program, the Doula Medicaid Project website. And there's a QR code there where you can find that. This website has nearly everything about the doula efforts in California right now. They also show the doula Medicaid efforts in other states as well. There's an entire spreadsheet. But for Californians, if you scroll down the page, you'll get to this part of that page. It says California Doula Pilots Lessons Learned Project. And at the very top link there, the summaries of California doula pilot programs. If you click there, you'll see a summary of doula pilot programs that span from Southern California to Northern California. They talk about the AIM initiative at LA County, the Frontline Doula program. They talk about Sister Web in the North Bay, doula programs in the Inland Empire and Contra Costa County. I only say this because this is a great start if you're sitting there right now and you're saying, well, this is all great, but we don't know what doulas or doula organizations there are in nearby. Well, this is a great place to start to give you that information. Although this webinar is not about the Medi-Cal doula benefit, we get a ton of questions about that. So upcoming, there is a two-part series on September 7th and September 14th about the Medi-Cal doula benefit. It's sponsored by various organizations, including Beauty for Ashes Maternal Wellness, and Michelle is here today representing that organization, but also Birth Workers of Color, the awesome folks over at Frontline Doulas, Black Infants and Families, and LA County Public Health. So tune into that if you want to learn more specifically about everything that's coming together right now in the Medi-Cal doula benefit. And we also have some other resources for you. The first one, there is a CMQCC webinar from a few years ago on incorporating doulas into your hospital, both understanding community-based doulas and hospital-based. There's also a CMQCC webinar by Ann Fulcher, who's on the panelists today, about specifically more involved about the volunteer doula program at UCSD. And then there's also a great little YouTube video there about the UCSD program. And then finally, another reminder that the final webinar in this series will be on October 25th from 12 to 1:30 p.m. about community birth, improving transfer of care. And here's where you can direct your questions. And finally, let's move to our panelist discussion. So I'm going to stop my share and ask that the panelists turn on their cameras. Hello there. All right. Thank you, Anne and Michelle, for being here today. Let's get started. And the first thing I'd like you to do is to introduce yourselves and maybe tell us a little bit about your story and what led you to becoming a doula. Why don't we start with you, Michelle?
Okay, hello, good afternoon, everyone, and I'm so happy to be here. Thank you so much for having me. So as mentioned, I am Michelle Sanders. I am the founder and executive director of Beauty for Ashes Maternal Wellness, Inc. We're a nonprofit organization. We basically provide doula support, other wraparound services to birthing folks all over Los Angeles County, San Bernardino County, and Orange County. And we also provide support to birth workers who support these families, right? Because it's very important to make sure that the birth workers are also being supported so that they can do this wonderful, beautiful work that we do. And so I have a background in healthcare. So I'm a certified surgical technologist as well, and also a lactation educator specialist. And I'm also a mom. That is like my proudest and biggest job. I'm a mom of 3, and I'm born and raised in South LA. And so it is really amazing for me to be in a position to serve my community in this way. And being a doula is something that I feel like I was born into. I've always done this work, but I never did it professionally until 2017, when I transitioned out of the operating room and into being a full-time doula. I was a part of the team and largely responsible for leading out the launch of the AIM Doula program in 2019. And I'm still very connected and very much a part of the AIM initiative, which Holly mentioned earlier. And, you know, being a doula is rewarding for me, but it's also like really hard work and really heavy. And so, you know, I'm just happy to be able to continue to share and get information out about doulas and what we do and how we can support everyone, you know, collectively to get better birth outcomes.
Thanks so much, Michelle. Go ahead, Anne.
Thank you. Hi, everybody. So Anne Fulcher, I am privileged, I think, to lead our UCSD volunteer doula program, which I've been doing for 23 years. I've been a private doula myself longer than that, 29 years and counting. So I have kind of a unique role of working within the community at other facilities, home birth, freestanding birth centers, and leading this volunteer doula program in a teaching hospital, UC San Diego Health. And I think that's important to say because it's, in my opinion, one of the reasons for our successes so far is because we're in an institution with a lot of learners and a lot of openness and willingness to change along with the times and change with evidence changes in maternity care. I started way back when with a background in things like marketing and communication and human resource management. And I kind of fell into it backwards when I started working for a breastfeeding organization and learned a lot about breastfeeding first. And then the obvious question, what happened before this breastfeeding dyad? You know, what was a dyad when it was just a pregnant person. And I became the house doula for the people I worked with just by accident. Later, I took training, got certified, and the rest is history, as they say.
That's a wonderful way to explain it. I think for a lot of birth workers, we can say we fell into it backwards, right? Like it is kind of a similar story all the way around. So I also want to note that there are some questions in the chat, and to those folks, there's a couple questions right now that I think we are going to answer. You'll see during the course of these interviews, and if not, I'll be sure to keep these so that we do towards the end. All right, so I'm going to start with some questions. Some of these were ones that I created, some were from others that have been asked on previous webinars, for example, and previous meetings. So apologies for reading these a bit robotically. I'll try to ask them as much like a reporter interviewing folks as much as I can. Okay, so for Anne, we'll start here. The volunteer doula program is the typical program that exists in California, and there are only a few. Do you know of hospitals anywhere that pay doulas as staff? And secondly, what are the components of a volunteer program? You've done this for years, and there's probably components that people aren't even thinking of at this point. So in short, what makes the wheels keep turning for a program like this?
Okay, so the first part of your question, are there programs that pay doulas in-house? That's a rare thing. Whenever money comes into play, then you talk about budgets, and budgets come and go. There was a hospital here in San Diego that had a group of, let's say, vetted doulas who were trained elsewhere and were screened by this hospital and were offered to their patient families as doulas that they would recommend them to hire. So they were paid actually by the families, and the hospital took a cut. So that's a little bit different than the hospital paying for the doulas, but that's the closest thing I can think of. That lasted quite a number of years, but it is not happening now. I don't know if COVID had a hand in that. But the way our program works is that we train and rigorously train and screen our volunteers in-house and provide them ongoing mentoring, training, and facilitating their communications with the families and the healthcare staff, to the point, as you said, Holly, our doulas are seen as part of the healthcare team. And I know we're going to get into the topic of, well, are you kind of just puppets of the hospital, to put it bluntly. But our work has been going on for over 20 years. We've served families and pregnant people from all walks of life, including refugees, unsheltered people, those with substance abuse disorders, incarcerated people, people with very high-risk pregnancies who don't typically see or know about doulas, and they do run the gamut of cultures. So although there's a certain segment of the population, if you will, who can afford, who have that benefit or privilege to become volunteers, our doulas do advocate very, very well for the patient population they serve, I think because they're welcomed in the hospital. We started out with grant funding, first with the First Five Commission and then the California Endowment, second grant. That was years ago, and since those grants ended, the next 18 years that we've been working have been funded through UCSD because of the benefits, the obvious benefits that you noted, clinical benefits that pay my salary. I have a part-time assistant, but the rest is all volunteer.
Thank you for that. I want to ask Michelle, we talked a little bit about doulas as advocates, community doulas as advocates and connectors to services. On the advocate part, can you give examples of what this means in real life? More specifically, on the practical level, when you or a doula from your organization is with a patient during labor at a hospital, in what tangible ways does this person advocate for and protect a patient, being specific to bias, racism, disrespect, fear, etc.?
Yeah, so I think when most people think about advocacy work and doula work, they picture the doula kind of showing up like a spokesperson or like a bodyguard, you know, in a sense, to stand between like the birthing person and the healthcare providers, right? But in reality, like a doula's primary role, in my opinion, is that of an educator, right? And so we promote self-advocacy, and we do that through educating our clients, making sure that they have the information that they need, that they are equipped to give informed consent, right? And to also see themselves as a very important, if not the most important member of their care team, right? And so sometimes advocacy can just look like, you know, asking a question just to offer a provider the opportunity to slow down and have like more patient-centered communication with your client about whatever's going on. Sometimes advocacy could look like supporting a client and, you know, having a conversation with the charge nurse to request that, you know, a team member can be reassigned or swapped out or something. Like if a provider is showing up in a way that's like disrespectful, physically or emotionally harmful to a birthing family, you know, it's good for us to be able to help advocate to get someone else in, because a lot of people don't even understand that you can request to not have this specific nurse and have another nurse be a part of your care team or something like that. And sometimes just the presence of a doula itself is advocacy, right? And so being in the room as an experienced professional, being like an additional set of eyes and ears, can very easily help change the way that a family is treated sometimes. And it can help bring accountability in situations where it's needed, right? And that can be in a prenatal visit, that can be during labor support, or in a postpartum visit. And so, you know, where there are instances where a doula will have to speak or speak up or speak louder sometimes if a patient is not being heard, a lot of it is about self-advocacy and just being there to help bring accountability in the situation.
I see. Thank you. On that, when you are in the hospital setting, for example, when a client comes in from a community birth and is transferred in, or maybe you're simply with the client already in the hospital setting where they intended to birth. And this question is also for you as well, given your decades-long experience with connecting nurses and doulas. Can you talk a little bit about how, and this is actually a couple of people's questions in the chat right now, how do the role of the doula and the labor and delivery nurse coexist? And how do you have any tips for getting staff comfortable with the role of doulas and that balance between the doula doing their physical support and the nurse doing their clinical support? But sometimes it intersects, or communication absolutely has to intersect at some point. Can you give some tips on that? Because that seemingly is one of the biggest barriers of entry when folks come in with a doula.
Right. So like you said, communication, right? So of course, you know, technically I've been doing this for about 26 years, right? And even like within the last 10 years, I can't count how many times I've come in with a client, whether it is a transfer or we were always planning to be at this facility, but having a labor and delivery nurse who really doesn't truly understand what a doula is and what we do, the type of support we provide. And so, you know, it's been honestly very helpful just to have a really honest conversation with them to try to help them understand what the role is, why we're here, and even helping them to see how like we are a team, really, essentially. Like we're here both for the same goal, right? We want a healthy mom, healthy baby, you know, a good birth experience. And so typically when you have a situation where we're at the hospital, you know, this nurse, and especially now with like staffing shortages, right? These nurses sometimes have so many patients that they're responsible for. But if you have that patient who has a doula with them, then they have someone who's there with them consistently. And so you can honestly like rely on that doula to be that person, to be there to comfort that patient, because you may not be able to do it in the way that you would want to do it for this number of patients. And so it could be something as simple as going to the nutrition room to get the juice or the water or the ice chips for the client instead of the nurse doing that. It could be something as simple as helping facilitate position changes. You know, the nurse isn't always available to do that right away. And so, you know, really just helping the nursing staff to see us as more of a teammate, and there's not really opposition between us. It shouldn't be. And then we can just work together in a smoother way.
Thanks for that. And do you have anything to add in terms of tips to improve that communication or ability to work together as a team?
I love everything you said, Michelle, and I agree with it all. We do need to just communicate together with the rest, whoever's in the room. But we do, as doulas, find ourselves most of the time with nurses who are the other people that are more frequently in the room than providers, let's say. So making friends with each other, I think, helps support the patient family. And some of the things we've been able to do at our program here in San Diego, because we've had the benefit of some funding, grant money and then donations. We get a ton of donations, is to pay for spinning babies classes. And I think the people who are listening to this webinar know what that is. It's kind of a funny name for a very useful set of teaching tools regarding maternal movement. And so we paid for classes for our doulas, for anybody who wants to take it. So a lot of our nurses have taken spinning babies. Some of our providers have taken it, and the doulas, and we got to know each other better that way in a kind of a fun, hands-on way. We put some money into it and said, hey, we'll do this. And then when we're talking with the nurses, we can say, hey, what do you think about, this spinning babies move at this point in time? And I usually do that outside of the room because I want to make sure it's okay with the staff that I'm working with before I suggest something to the birthing person, because sometimes they know something I don't know and they have a reason why they're not comfortable with it. But working together, communicating every step of the way. I love what you said, Michelle, about, going to get a blanket or some ice chips or water or something and taking a load off the nurses. They really appreciate you and see you in a collaborative role. So what you said.
That's lovely. Actually, it's a great follow-up because you mentioned this joint educational thing that the doulas and some of the providers and nurses did together, and that deepened their understanding of each other and each other's roles as well. And so this leads me to a question more so for Michelle, coming into it from the community standpoint, but it was a good lead in nonetheless. Day before yesterday, literally day before yesterday, I heard about a hospital system in California that is unwilling to even learn about more local doulas because they, quote, aren't part of the care team. And so this, of course, is not what's recommended in the toolkit. We name various strategies for communication between the community and hospitals, even joint learning sessions, as Anne just noted. But it starts with getting to know each other. That said, some places may be fearful of, well, how do we do that right? How do we get to know each other? In your experience, what have been some of the most simple and effective ways that community doulas and hospitals have started to get to know each other?
So, it's, again, it just goes back to the communication, right? And so sometimes they're fearful because they don't understand what we do and why we do it, and that, we're not working against them, right? And so a conversation can help, squash all of that, and then we can move forward. But like for Los Angeles County, none of this work that we do is easy, but I will say that it is easy because we have the AIM initiative, right? In Los Angeles County, it's a countywide initiative. And there are so many opportunities for any and everyone to join and participate in the work that's being done to address this Black infant and maternal health crisis that we have, right? And so it doesn't matter if you're an OB, an RN, lactation provider, mental health provider, pelvic floor specialist, any other provider, or even hospital admins, right? You can come and connect with community members, members from, the Department of Public Health, faith-based organizations. Like, we're all together and we're having these opportunities to have conversations. We have work groups, and everybody gets a chance to participate and help have their input and, help us, build whatever this is that we need to support, these healthy, joyous births that we want to see. And so, there's things going on in other communities, right? Where you can come in and volunteer your time. You can come in and get to know who is in your community doing this work and get a different understanding. It's always a pleasure for me when I go into a facility and there are nurses and other providers who have taken spinning babies, who have taken some doula trainings, or even when the nurse finds out that I'm the doula and they say, I want to become a doula. Do you offer doula trainings? And I'm like, yeah, it's amazing when nurses come in to be doulas or when doulas become nurses, right? And so just understanding who everyone is, what the roles are, how all of this intersects is so important. And so it doesn't have to be like heavy though, these conversations. Sometimes we have like really fun interactive like engagements, right? So for Black Maternal Health Week, a community-based organization sponsored like really just like a celebratory event. There was food, there was music, there was dancing. And in the room, you had doulas, you had hospital admins, you had OBs, you had community members, and we just hung out together. And so now you're building relationships. And now when we get into a facility, this is a familiar face. This is a person who you know and respect and have built a relationship with, and everything just works out so much better.
That's great. And so really a key tip there is being involved in the community, going to these events as yourself a nurse, as yourself a provider or a administrator at the hospital, and learning what it's all about. And would it be accurate to say that it's as simple as picking up the phone, calling one of these organizations and say, I saw your information online, I'm from such and such a hospital, and we want to learn about you and see what comes out of that?
Absolutely. Like, you know, for the AIM initiative, you know, we're on social media. You can go to Black Infants and Families Los Angeles and connect there. It's very easy to connect, and you have so many options of where you want to connect, right? So we have like family-centered models of care. You know, we have like the, you know, philanthropic portion where people are, you know, working to, you know, get funding and help organizations to do the work. You know, you have, you know, of course, the doula program. And so there are so many opportunities for folks to support and, you know, move around and just figure out who's who in this whole big thing, and then get in wherever you fit in, you know, where you feel comfortable. And so sometimes, like, I mean, yesterday, I can use the example, like, you know, I'm sitting at a table with a midwife who is my mentor and also my actual gynecologist. And we're all in the room together and we're just hanging out, having a good time, you know, and this is what it takes to move the needle.
It really is just all about relationship building. I love what you said there. Get in where you fit in and make it work. That's a perfect line. And I have a question for you. Today we have presented two different models of care, the hospital-based doula model and the community doula or community collective model. For facilities that say, this sounds great, this is wonderful, everything presented today sounds really good, but we actually don't see the necessity for having or, you know, thinking about a volunteer doula program because various things. Maybe we already have midwives, or because people can hire their own doula, because, you know, there's the Medi-Cal doula benefit now as well. So what do you say to folks about the benefit of this program, given that these preconceived notions might exist? They might be accurate, but they might exist and have the potential to derail some innovation even before it starts.
Boy, that's a big question. I'll start with, if I had a nickel for every time people said, isn't that the same as a midwife, or why do you need both? They're very different roles. And again, I think our audience here does understand that. One of the benefits of our program is that we have doulas for all, and that doesn't mean they're, you know, the best match of culture or ethnicity or anything like that, but there's obviously a significant benefit when doulas and families do match. But we're ready for all the diversity, and our healthcare team knows it. And I'll have a recent example too. We had a very, very young refugee woman from Ethiopia, and who, terrible story, but we tried to match a doula from her community with her and found that there wasn't a doula, but there were people willing to come and be with her, but they couldn't stay. So they were intermittent. We pulled a doula in who had a little Arabic background herself, and she stayed for 26 consecutive hours. And the nurses saw the benefit of the mix of community-based supportive person and the doula who knew the culture of care in the hospital, had a little bit of language, and could stay. So we really saw how it's not either or. There's room for all types of doulas, I think. And in fact, I want to say, at this point, when there's such a need to train up doulas, community-based doulas, private doulas, every other kind, getting any more doulas into the mix, I think helps normalize their presence. And for hospitals who just aren't sure what the heck a doula is or heard stories and aren't sure they want them around, it really helps when there's a reluctance to go, okay, well, these doulas, at least they're cool, we'll let them in. And it's like, well, let us all in, because here's how we can communicate and work well together. And I'll tell you another little story. We have a fairly significant Haitian refugee population coming through sometimes. San Diego sits right on the border with Mexico, right? So we see people coming across the border, and there's an unfortunate, high rate of HIV status in certain populations, and they don't necessarily want a doula from their community because they don't want people to know their HIV status, or for other reasons where they might want a stranger, believe it or not. So I think there's room. There's such an increasing need to provide doulas. I love what's happening with community-based care being supported and funded. Medi-Cal doulas. Also, one thing that hasn't been mentioned here is TRICARE, which is the military insurance, who are also paying for trained and vetted doulas. San Diego is also a big military town, right? We have Navy and Marine stations here. And we have about 12 or 13 TRICARE approved doulas now who are getting paid. And I'm no problem with paying doulas, believe me. But I will say that there are people who want to volunteer without a paycheck involved. And I think we don't have a lot of time, but there are different reasons why people become doulas, and there are different currencies, if you will, for paying doulas. Not all of it is with a paycheck and the associated tax paperwork that has to be filled out at the other end of it. If, for example, they're coming for a depth and breadth of experience and support so that they can go out, get certified, get a paycheck that way, or want to become private doulas for pay, want to become nurses, midwives, physicians, and they're more than willing to look at this as an apprenticeship in which they're willing to do it the way we do it, which is on call, meaning they sign up to a schedule to answer some of the questions in the chat here. Our doulas sign up AM or PM. They commit to staying for the birth, no matter how long it takes. They commit to staying with UCSD for 6 to 9 months. And yes, we do set a small fee for the training. We used to do it for free, and people didn't, you get what you pay for, I guess. They didn't take it seriously. So we put a little fee, quite subsidized cost for the training. And, I offer scholarships if I can to people for whom that's a hardship. That was a lot.
That was a lot, but thank you. You are so efficient at getting through the chat as well and making it flow into your conversation. So we appreciate that. You did mention that you fully understand that there is a benefit to having community concordance or racial concordance with the patient, but that clearly there are situations in which a person can benefit by having a person there with them and may not even have known that a doula is possible, or may be alone in labor, or may be having this long labor, have partners with them and family with them who no longer have the capacity to continue their support, and the doula might even follow with them into the C-section. Sometimes that can happen as well. So I appreciate that viewpoint on how all comers are welcome in the doula space, and how that expands the knowledge and understanding of what both community doulas and hospital-based doulas are attempting to do. On that note, Michelle, there is a lot of research on racial concordance and cultural concordance, and or even just community geographic concordance with one's clients between doulas and patients, that makes for a stronger benefit to the patient. I imagine there might be some people on this call who may be new to the concept of how structural racism, even if the provider or the hospital or the nurse, et cetera, is not intending to do so, but nonetheless exists in real time. And that creates outcomes that are disparate for Black birthing people and other people of color. Can you talk specifically from your point of view how doulas are not just a strategy, but perhaps one of the most meaningful strategies to reduce racism-based disparities in reproductive health, and why?
So when we see racism in care settings, like sometimes we as the doula, like we're able to act as the buffer for our clients, right? And like, so, there's been some situations where I was on the receiving end of that racism or discrimination by hospital staff before it even got to my client. But knowing now that this is what we have in the room, able to then kind of like, shield my client from that to a certain extent by, stepping out with the nurse, talking to the charge nurse before this birthing person even had to experience this, negative thing. And so, and that is something that unfortunately does weigh heavily on the doula, right? But, as a Black woman supporting other Black women, there's mutual understanding on like what it means to be on the receiving end of like unfair treatment, discrimination, neglect at the hands of the care team that's supposed to be caring for you. And then the burden usually falls on those who have been treated poorly to help those who have committed the offense understand or even validate, right, this interaction. And that's not our job. This family is like processing this birth experience and now having to deal with, the racism and the discrimination that took place during this experience. And so, it's especially not the job of a postpartum parent, a newly postpartum or pregnant person who should be focused on preparing for their baby or bonding with their baby. And so, when you have like this cultural congruence or these like shared lived experiences, we can come in and just from a different perspective, like connect with that client, help them process, right? Whereas sometimes, if you don't understand, like for me, when I was a surge tech, I was a traveler. And so when I went to a different state, I didn't necessarily understand like what was going on locally there, what might have taken place before I got there that's now affecting this situation, what stressors this patient may have just because of where they are geographically. And so when you have people who are representative of your community and, culture and things like that, it just makes it easier for us to support each other and understand each other. And so that's why it is important to have this cultural congruence. Although, some people, it doesn't matter if the doula looks like them or not, they just want the support. And so I feel like it doesn't matter where a birthing person falls. If they want a doula, they should have a doula. If they want a doula who looks like them, we need to do the best that we can to find a doula who looks like them. And it should be supported across the board. Facilities, community-based organizations, anybody who has a hand in this, we need to diversify the workforce so that we can have more doulas that look like our diverse population.
Absolutely. And that kind of leads into this next question. So you've talked a lot about advocacy, being there for the patient, feeling what, being able to feel what they feel, know what's available in their community, et cetera. So on that note about community doulas as connectors to services, in some ways it seems like doulas often function as half doula, half community health worker. Can you give an example of how your program or other programs you've worked in connects clients to what they need or directly provides them with those services, whether that be during the prenatal or postpartum period, a typical story, or even just a personal example?
Yeah, so typically when you take a doula training or all doulas, it's suggested that you have a resource list, right? A list of folks to pull from, to connect people to, right? And you need to make sure that you update that list regularly to make sure that this is like a warm handoff, like you're not just giving people a phone number or a website to nowhere. So, making sure that you have relationships or build relationships with other care providers that serve this birthing population also. But, sometimes we're dealing with like, social determinants of health. And we're dealing with things like, food insecurity, job insecurity, housing insecurity, and things like that. And so like for Beauty for Ashes, like I said, we offer doula support, but also wraparound support. We do get clients who are unhoused and pregnant. And so sometimes that means helping to connect them to resources to get them in housing. And sometimes if we can't do that quick enough, and if we are blessed to have the funding, then we can put them somewhere temporarily to get them off of Skid Row. We have had to provide childcare for, a mom who had a young child, but also was about to go in for a scheduled cesarean to, birth her new baby, but she didn't have anyone to take care of her 5-year-old. And the only advice that she got from her caseworker was to basically relinquish your child to the Department of Children and Family Services for your birth. And of course, that was the scariest thing for her. So we were able to set her up with what we call birth babysitting. Some folks offer 24-hour childcare. And so we were able to, cover the cost of that so that she could go and have her baby. We also gave her a doula, of course, so she wouldn't be there alone, and made sure that her 5-year-old was cared for. Sometimes, people just don't have the things that they need. And so we use funding also to get the items that people need to take care of themselves and take care of their babies. And so, being a doula, yes, we're focused on this pregnancy, on postpartum, on breastfeeding, but also we're focused on, do you have food in your refrigerator? And if you don't, how can we help you get some? Even being in a position as a nonprofit organization, being able to use funding to make sure that a mom can get to her postpartum visit. And so, sometimes we see that, the baby will go to their checkup, but mom doesn't go to her postpartum visit because she doesn't have childcare or transportation. So we're able to jump in and, make that happen. So now we can get mom to her postpartum visit. So those are just some of the other services and the other ways that we can support.
That's wonderful. And in some ways, like you said, that birth babysitter idea might be something that other people might not even know about. Patients might not even know, providers don't even know, but you're uniquely positioned to know that exists.
I mean, the need came up and we always have to pivot when people present with needs. We didn't expect it, but hey, this is an emergency. How can we fix this? What can we do? And that's what we did.
It's wonderful. Amazing. For Anne, the question has come up that some people, and I think it was in the chat previously for a short time, and I knew that we'd answered it, that some people worry that volunteer doulas, once integrated into the hospital system, become extensions of the dominant care model, much like there is evidence happens with midwives in hospitals when they begin to practice in a way that is, for example, higher intervention, less hands-on, et cetera, or just simply begin to follow the policies of a place rather than doing that deep patient listening and advocating for the patient.
I think that's such. Oh, sorry.
Yeah, how do you promote even a volunteer doula program that these doulas can act independently and advocate on behalf of the patient in that independent way?
It's such a good question. It's reasonable to think that would be the case. I'm sure people have seen that being the case. I can tell you that when people see you as part of the team, they listen to you versus when they see you as an outsider. That's part of what justice is all about anyway. Our doulas have earned this over 20 odd years. We've had a couple of doulas who had misguided and outspoken ways of trying to advocate, and unfortunately, weren't able to resolve that. So our doulas do have to be professional, but they're listened to because they're seen already as, these doulas are trained and vetted and part of, they get what's going on here. And for example, I once was in a birth where there was a retained placenta after a lovely medicated birth. She had an epidural, and I said to the doctor, I said, hey, have you ever gotten anybody in a squatting position? I've seen that work. And she went, oh, Anne, yeah, no, we're not doing that. And she wasn't comfortable with the idea, and I didn't push it because I could see, because I know her, she didn't want to be embarrassed to say, I don't know anything about that, I don't know how to do that, I haven't tried that, I'm not comfortable with that. But she didn't shut me down. She called me by name and said, thank you for bringing that up. And I think in the future she did try it, but she wasn't ready that time. And we actually talked about it outside of the room afterwards. So was I successful in getting somebody into maybe a position? Who knows whether it would have worked or not, but I was, I think, successful in having a dialogue with that provider and opening her eyes to the possibility. And she listened to me. She did not just think, oh, those crazy doulas. And to me, that felt like such a big win. Our doulas, by the way, are allowed where other, private doulas are not, partly because of COVID. But Holly, as you mentioned, we go into the OR all the time, and not just like when the family member does, we go in for the prep. But family members and private doulas are not allowed to. So I think it's taken us a long time to be seen in the light of more benefit than harm. Somebody said to me once about our program, oh yeah, I like UCSD doulas. They're like the honeybees that keep out the killer bees. And that tells us all that there have been some situations or stories enough that people don't trust doulas always. So having doulas in the mix to be more familiar to people who have concerns is a benefit for all of us. And as far as competition, I'm reading some of the chat things. There's room for more doulas than we have. We can't train doulas fast enough right now, I think. And I do train doulas for the community who aren't going to stay with our program. There are some requirements of our program that some doulas don't want to meet. For example, they have to be COVID vaxxed. And I, by the way, also train our nurses now in labor support skills. And that's another area where we can connect and find a community of, we want the best for everybody in the room, healthy mother, healthy baby, but we don't all come at it from the same way. And I've had nurses tell me, I just don't know what the doulas are doing when I'm not in there. And they come up with these crazy ideas. And I don't like unmedicated birthing people because they scare me and they're loud and I don't know how to help them. So I now teach an 8-hour class for our incoming L&D nurses on labor support. And I don't think I could have walked into a hospital and said, I'm going to do all this. So to those of you contemplating a doula program, start tiny, start really small and with gratitude and listen to everybody's concerns. And it takes top-down support. To answer another question in the chat, we were very fortunate early on. We had the chairman of reproductive medicine, the director of volunteer services, the director of women and infant services, happened to all be people who were excited about the idea of starting a doula program. And I think if you don't have that top-down support, it is going to be difficult.
Thank you for that, answering that question as well about who needs to be in the room to start these discussions. So, we've just discussed now this idea of nurses and doulas working together and how, they can balance each other out. But there are times from the medical standpoint, from the care provider standpoint, and this is a question for both Michelle and for Ann, and this question comes from the chat, where it can be that the doula is advocating for something that the care team thinks is contrary to their suggestions or feels is not safe for the patient. How do you kind of come to what happens in those situations and any suggestions for how the care team can move forward?
Take that, Michelle. Yeah.
I mean, so I saw the question, and so it's like, first of all, understanding that it's not the role of a doula to give advice. Like, we don't give medical advice, right? Some of us are medical providers like myself, but it's not my role or my position to give medical advice and to tell my clients what they should be doing, right? What we're doing, we're providing evidence-based information and education to our clients so that they can then make a decision about the care for themselves and their baby. And so sometimes, there's kind of, this butting of heads, so to speak, because we may have a provider who does not subscribe to this particular piece of evidence-based information. But typically, we're saying the same thing to the patient, to the client, right? When it comes to like, what is best practice for this, that, or the other. And so, I think of the example where, I was in the position where I did have to stop a doctor from doing an episiotomy. And this was a physiological, just natural, unmedicated birth, labor. Mom was doing really, really well. And so my question to the provider was, do you know how to facilitate this process without an episiotomy? Because I had already learned that this is what he does. He's old school. And I'm like, mom's doing really well. And, I understand, like, hey, you think that this is the best way to go, but like, look at the situation as it presents in front of us right now. And there's no risk here, like if we cut or don't cut, that, something like horrible is going to happen. And he stepped back and he said, I mean, like, obviously, yeah, I can do it without an episiotomy. And I said, okay, well, let's. And we did. But it was just somebody speaking up. And even the nurse said, like, I've never stood up to Dr. such and such. And I'm like, hey, I'm a scrub tech. I stand shoulder to shoulder with doctors all the time. They don't scare me. So, and I'm like, hey, let's just talk about it. And so, but if a doula is advising, they shouldn't be. If a doula is coming in and like being disruptive or obstructive to care, they shouldn't be. And so we might have to, again, like Ann said, look at what this doula is doing and, get to the bottom of why this doula is showing up this way, because that's not even what we're there to do. So sometimes, like if it's a hospital-based doula program, obviously you could talk to the coordinator, talk to Ann, right, about what's going on with this doula. If it's a community-based doula program, let's get back to the, leaders of that community-based program, or just having a conversation with the doula, nurse to doula, doctor to doula, after we've, gotten mom and baby taken care of.
Fair enough. And it's funny, it's so simple, right? But in the moment, it does seem so complex because communication always is such. Anne, do you have anything to add to that?
Yeah, I would love to just follow on with Michelle's words and say that I think that the healthcare population is still trying to figure out doulas, and they are interested in what kind of training do they have and who do they report to and what do we do if we have a complaint or a compliment. And I've become, because I have this gloriously unique role. I work full-time on the labor and delivery floor of our hospital, so I'm very visible, and people will come to me with all kinds of stories, like good and bad, and they can come to me about private doulas or our volunteer doulas or community doulas, and say, this happened, what do you think? And I can explain the doula's perspective, or I can say, oh yeah, that's a little out of scope of practice, what's her name, I'll call her. That might not be my job, but I do it because, Michelle, like you, I'm not afraid of talking to people. It's words and communication, and sometimes it's hard, but it's better than leaving it unsaid. And if people know that there's some form of accountability and some oversight to this increase in doulas that they're seeing in their patient rooms, they're going to just feel more confident that issues can be resolved.
Agree. That's a perfect way to say it. So we're almost at time. There are 2 questions left in the Q&A that I'd like to get to, and they seem fairly simple to answer. But the first is, do you know of any doctors who have partnered with doulas as their practice model?
Yes, of course. Like there's plenty, right? And it's very exciting because, people think doctors and doulas just don't get along, and that's not true. And so if I can say by name, 2 of the OBs at Kaiser West LA here in Los Angeles County, they've taken a stand to say, like, every patient that they have who comes in, every pregnant birthing person, they say, hey, do you have a doula? If not, you need to get one. And so this is the OB saying, like, I need you to have a doula. And that does so much for, just normalizing having doula support along this journey. And so that's Dr. LaTanya Hines and Dr. Sylvester. What's Dr. Sylvester's name? First name, I forget. But, just them being providers saying, like, yes. And there's a doctor who I worked alongside at Cedars-Sinai who came into the room, said, hey, you're the doula, right? And I'm like, yeah. And he's like, you're in charge. And I'm like, in charge of what? And he's like, today, I'm going to watch what you do. And then after we finished, he said, yeah, I learned some things and I'm going to steal that and use it because it just made sense. And so, again, like a doctor who really understood and respected what we do as doulas and we've built a relationship just from that one interaction. So there's plenty of doctors who say, like, this is definitely a tool that I need to have in my back pocket, connecting my patients to doulas.
Gotcha. And then how does the doula's charting work with the hospital's charting and or nurses charting? Do the are they separate things and remain separate things? And of course the answer is yes, but maybe have a deeper response. And then also, do the doulas take baby-friendly training?
I guess like for Anne, that would be more for Anne, because a hospital-based doula may have different requirements or things like that. But for, individual doulas, just typically doula charting is more about like for programs and like grant funded programs, especially, data collection, because, these programs are data driven. But, we're collecting that type of stuff. But again, we're not medical providers, so we're not necessarily charting in a way that a medical professional would. And then for as far as doulas being baby friendly, like that's just the nature of what we do, right? We are baby friendly. We are mom and birthing person friendly. It's just what it means to be a birth worker.
I can add to that just from our perspective here. Data drives everything, and we do have a separate database. We're not connected with Epic, but we do keep stats. I think every doula should be contributing to the statistic research, and our doulas are required actually yearly to take online training through UCSD on the topics of safety and HIPAA. And I wonder, I can't speak to how doulas, in community practice and private practice are keeping their stats, but I think it's great that they are. And CMQCC has been so instrumental in reporting and sharing all this info. So we've got to keep doing that. But it's a bit tricky because sometimes the nurses look at doulas like, what are you doing? Oh, I'm just taking notes, And so there's still so much room for more communication, more understanding about what each of us is doing on behalf of the people that we all want to support. I forget the second half of that question.
That's okay. In fact, we're at time.
And
I am so grateful for the expertise of both Michelle and Anne, and that you were willing to come on this webinar. We appreciate it. Thanks so much, everybody. Hopefully we'll see folks in October for our community birth webinar, and take care and have a great rest of your day.